Welcome back to the deep dive. This time, we're taking a deep dive into a condition that might sound a little complicated at
Oh,
first,
yeah.
pleural effusion. You've sent over a stack of medical textbook excerpts and some recent research articles, so I know you're ready to get into the details.
Absolutely, and I'm excited to help unpack all of this.
Yeah.
Pleural effusions are fascinating
Yeah.
because while the basic idea is pretty straightforward,
Uh-huh.
the causes and implications can be quite diverse.
Exactly. And one of the most important things to grasp right off the bat is the difference between the two main types of pleural effusion,
Right.
transudative and exudative.
Yes.
This distinction isn't just medical jargon, it's actually the key to figuring out what's causing the effusion in the first place.
Right.
It's like finding a footprint at a crime scene.
Uh-huh.
It gives us a starting point for our investigation.
That's a great analogy.
Yeah.
Let's start with the basics.
Okay.
A pleural effusion is simply a buildup of fluid in the pleural space, which is the area between the lung and the chest wall.
Oh.
Think of it like this. Each lung is encased in a thin, slippery membrane called the pleura.
Okay.
And there's normally just a tiny bit of fluid in that space to help the lungs move smoothly when you breathe.
Okay.
But when that space starts to fill up with excess fluid,
Yeah.
it can cause problems.
Okay, so we've got this delicate balance of fluid in the pleural space. What happens when that balance gets thrown off
Right.
and we end up with the pleural effusion? What does that feel like for the patient?
Well, one of the most common symptoms is difficulty breathing,
Okay.
as the extra fluid puts pressure on the lungs,
Yeah.
making it harder for them to expand.
Hmm.
Doctors can often detect this by listening to the chest with a stethoscope
Okay.
with a pleural effusion. Breath sounds might be diminished or absent in the affected area.
Uh-huh.
There's also a technique called percussion,
Right.
where doctors tap on the chest to listen for changes in sound.
Uh,
A healthy lung sounds hollow when percussed,
yeah.
but a pleural effusion creates a dull thud because the fluid dampens the sound.
So it's like the difference between tapping on an empty drum versus a drum filled with water.
Exact.
That makes sense. Are there any other telltale signs that someone might have a pleural effusion?
Yes. Sometimes if the effusion is large enough,
Yeah.
it can actually push the trachea or windpipe
Okay.
to the opposite side of the chest.
Wow.
It's like the fluid is taking up so much space that it's displacing the trachea.
Yeah.
And of course, the patient might experience pain,
Yeah.
especially when breathing deeply.
So we've got difficulty breathing, diminished breath sounds, dullness to percussion,
Right.
and maybe even tracheal deviation. Those are some pretty clear signs that something's going on.
Yes,
But as we mentioned earlier, the real mystery is figuring out what's causing that fluid buildup.
exactly.
And that's where the distinction between transudates and exudates comes in.
Exactly. You see, transudates and exudates are like two different flavors of pleural effusion,
Okay.
each with its own set of culprits. Transudates are typically caused by imbalances in pressure within the blood vessels, forcing fluid out into the pleural space. Imagine a garden hose with a tiny leak.
Yeah.
The water pressure pushes water out through the hole, creating a puddle.
Uh-huh.
It's a similar concept with transudates.
Okay.
Increased pressure in the blood vessels, often due to conditions like heart failure, liver failure, or kidney disease,
Right.
essentially pushes fluid into the pleural space.
So it's not that the pleural space is actively attracting fluid.
Right.
It's more like the fluid is being passively squeezed out of the blood vessels.
Yes.
Due to pressure imbalances.
That's right.
Okay.
It's like a plumbing problem,
Yep.
where the pipes are backed up, and
Right.
the pressure forces water out in unexpected places. Now, exudates are a different story.
Okay.
They're caused by conditions that directly affect the pleura itself,
Okay.
leading to inflammation and the leakage of protein-rich fluid. It's like if that garden hose had a hole that was actively oozing out a thicker, more viscous fluid,
Right.
not just clear water.
Okay, I'm starting to get the picture here. So with transudates, we're looking at systemic issues like heart failure or kidney disease
Right.
that indirectly cause fluid buildup. But with exudates,
Yes.
we're dealing with something going on directly in the pleural space itself.
Right.
Inflammation or infection.
You got it. And this distinction is crucial
Okay.
because it completely changes the way we approach diagnosis and treatment.
Yeah.
If we identify the effusion as a transudate,
Uh-huh.
we know we need to focus on managing the underlying condition
Right.
causing the pressure imbalance.
All right.
But if it's an exudate,
Yeah.
we need to investigate what's happening in the pleural space itself.
Mm-hmm.
Is it an infection? Is it cancer?
Yeah.
Is it an inflammatory condition? Answering these questions is essential for determining the most appropriate treatment.
All right, so we know that the type of fluid transudate versus exudate is our first big clue.
Yes.
But how do doctors actually figure out which type it is? I imagine it's not as simple as just looking at the fluid.
You're right. It's not just about appearances. Luckily, we have a set of criteria called Light's criteria
Okay.
that helps us distinguish between the two. It's like a set of rules that doctors use to analyze the fluid
Yeah.
and determine whether it's more likely to be a transudate or an exudate.
Light's criteria, it sounds almost like a secret code.
Yeah.
What exactly are these criteria and how do they help us crack the case?
Think of Light's criteria as a three-pronged test.
Mm-hmm.
It involves comparing certain values in the pleural fluid to those in the patient's blood.
Uh-huh.
First, we look at the protein levels. If the protein level in the pleural fluid is more than half of the protein level in the blood,
Yeah.
it suggests that the fluid is an exudate.
Right.
Remember, exudates are protein-rich.
Okay, so higher protein in the pleural fluid points towards an exudate.
Yes.
What are the other two prongs of this test?
The second criterion focuses on an enzyme called lactate dehydrogenase, or
Okay.
LDH. This enzyme is released when cells are damaged, and elevated levels in the pleural fluid can indicate inflammation or infection, again pointing towards an exudate.
Right.
We compare the LDH level in the pleural fluid to the LDH level in the blood,
Uh-huh.
and if the ratio is greater than 0.6,
Yeah.
it supports the diagnosis of an exudate.
So if the pleural fluid has significantly more LDH than the blood, it's another sign that something's going on directly in the pleural space.
Exactly. And finally, we compare the LDH level in the pleural fluid to the upper limit of normal LDH in the blood. If the pleural fluid LDH is greater than 2/3 of the upper limit of normal for blood LDH, that's another point in favor of an exudate.
So we've got three key ratios, LDH in the pleural fluid compared to the blood,
Yeah,
and LDH in the pleural fluid compared to the upper limit of normal in the blood.
right.
If any of these ratios are elevated, it makes an exudate more likely.
Precisely. And while Light's criteria are incredibly helpful, doctors don't rely on them alone.
Right.
They also consider other factors like the patient's medical history, physical exam findings, and the results of other tests performed on the pleural fluid to get a complete picture.
It sounds like a real detective story, piecing together all these clues to figure out what's causing the effusion. And speaking of clues, let's shift gears and talk about the usual suspects. What are some of the most common culprits behind transudative and exudative effusions?
Okay, let's start with transudates, those plumbing problem effusions we talked about earlier. As we mentioned, these are typically caused by conditions that disrupt the balance of pressure in the blood vessels, essentially forcing fluid out into the pleural space.
Mm-hmm.
One of the most common culprits is heart failure.
Okay.
When the heart isn't pumping effectively,
Yeah.
it can cause a buildup of pressure in the blood vessels leading to the lungs, and that pressure can push fluid into the pleural space.
So in a way, the pleural effusion is a side effect of the heart's struggle to keep up with its workload.
Precisely. And it's not just the heart-liver failure can also lead to transudative effusions.
Okay.
The liver plays a crucial role in regulating fluid balance and producing proteins that help keep fluid within the blood vessels.
Right.
When the liver is failing, these functions are impaired, and fluid can leak out into various body cavities,
Yeah.
including the pleural space.
It sounds like a domino effect. One organ failing can throw off the delicate balance in other systems.
Exactly. And we can't forget about kidney disease.
Right.
The kidneys are responsible for filtering waste products from the blood and maintaining fluid balance.
Mm-hmm.
When the kidneys aren't working properly, it can lead to a buildup of fluid and waste in the body,
Yeah.
which can also contribute to pleural effusions.
So we've got heart failure, liver failure, and kidney disease, all pretty serious conditions that can lead to transudative pleural effusions. What about exudates? What are some of the main culprits behind those?
Exudates, remember, are those effusions caused by inflammation or damage to the pleura itself.
Right.
And one of the most common causes of this type of pleural effusion is infection.
Okay.
Pneumonia, for example,
Mhm.
is a lung infection that can sometimes lead to a buildup of infected fluid in the pleural space.
Right.
This is known as a peritonic effusion,
Okay.
and it can be quite serious if not treated promptly.
So it's like the infection spills over from the lung tissue into the pleural space,
Right.
creating an inflammatory response.
That's a good way to put it.
Yeah.
And it's not just bacterial infections like pneumonia that can cause this.
Right.
Other types of infections like tuberculosis or fungal infections can also lead to exudative effusions.
It's fascinating how something that starts in the lungs can have such a significant impact on the surrounding tissues.
Absolutely.
Right.
And while infection is a major cause of exudative effusions,
Right.
it's certainly not the only one. Another culprit is cancer.
Okay.
Lung cancer in particular
Yeah.
can directly invade the pleura
Uh-huh.
or cause irritation that leads to fluid buildup.
Hmm.
This is called a malignant pleural effusion.
So in these cases, the pleural effusion is a complication of the cancer itself, not just a separate issue.
Exactly. And it's not just lung cancer that can cause this. Other types of cancer,
Right.
like breast cancer or lymphoma,
Sure.
can also spread to the pleura and cause malignant effusions. And then we have a whole category of inflammatory conditions that can affect the pleura and lead to exudates.
Okay.
Rheumatoid arthritis,
Wow.
lupus, and other autoimmune diseases
That's great.
can cause inflammation in various parts of the body, including the pleura, resulting in fluid buildup.
Wow. The range of potential causes is really quite broad, from infections and cancer to autoimmune diseases.
Right.
It really highlights how interconnected different systems in our bodies are.
That's one of the things that makes pleural effusions so intriguing. They can be a sign of a wide range of underlying conditions, and figuring out the root cause is like solving a complex puzzle.
We've talked about how doctors use Light's criteria to distinguish between transudates and exudates, but what other tools do they have at their disposal to pinpoint the exact cause of a pleural effusion?
Well, the diagnostic process starts with a thorough medical history and physical exam.
Yeah.
The doctor will ask about the patient's symptoms,
Okay.
past medical history,
Yeah.
and any potential exposures to infections or environmental toxins.
Right.
They'll also carefully examine the patient, listening to their lungs,
Uh-huh.
checking for signs of fluid buildup, and looking for any other clues that might point to the underlying cause.
So it's like gathering evidence just like a detective would.
Exactly. And once they've gathered all the initial clues, doctors often turn to imaging studies to get a clearer picture.
Okay.
Chest x-rays are usually the first step.
Right.
They can show the presence and size of a pleural effusion, and they can also reveal other abnormalities in the lungs that might provide clues to the underlying cause.
So we can actually see the fluid on an X-ray?
Yes, it will show up as a white area on the x-ray,
Oh, wow.
obscuring the view of the lung tissue beneath it.
Mm-hmm.
And if the x-ray isn't conclusive,
So,
doctors might order a CT scan, which provides more detailed images of the chest and can help identify smaller effusions or other abnormalities that might not be visible on an x-ray.
so imaging studies are crucial for visualizing the effusion and looking for additional clues. What about the fluid itself? Can we learn anything by analyzing it?
Absolutely. In fact, analyzing the pleural fluid is often the most important step in pinpointing the cause of the effusion.
Yeah.
This is called a thoracentesis,
Okay.
and it involves inserting a needle through the chest wall and into the pleural space to collect a sample of fluid.
Sounds a little intimidating,
Yeah,
but I imagine it provides invaluable information.
it does. Once we have that fluid sample, we can run a whole battery of tests to analyze its characteristics
Right.
and look for telltale signs of different conditions.
Right.
We can measure the fluid's pH protein levels,
Right.
glucose levels,
Yeah.
and LDH levels, just like we talked about with Light's criteria. But we can also do a lot more.
Tell me more about these tests. What kind of secrets can they reveal?
Well, one of the first things we do is look at the appearance of the fluid. Is it clear,
Yeah.
cloudy,
Mm-hmm.
bloody? The color and consistency can give us clues about what's going on.
Okay.
For example, cloudy fluid often suggests an infection,
Right.
while bloody fluid might indicate trauma or cancer.
Mm.
Then we look at the cell count.
Okay.
A high white blood cell count,
Yeah.
particularly neutrophils,
Uh-huh.
often points to a bacterial infection. On the other hand, a predominance of lymphocytes might suggest an infection like tuberculosis or even a malignancy.
So each cell type has its own story to tell.
Exactly.
Yeah.
And then we can take things a step further with cytology,
Okay.
which involves examining the fluid under a microscope to look for specific types of cells.
Yeah.
This is crucial for detecting cancer cells in the fluid,
Right.
which would confirm a diagnosis of a malignant pleural effusion.
That's incredible. We can actually identify something as specific as cancer cells just by looking at the fluid under a microscope.
We can. And if we suspect an infection, we can send the fluid for culture, which involves trying to grow the bacteria or other microorganisms in a lab setting.
Right.
This allows us to identify the specific culprit and determine the best antibiotics to use for treatment.
So it's like a fingerprint analysis for bacteria. We identify the culprit and then target it with the right weapon.
A perfect analogy.
Okay.
And sometimes we need to go a step further and test for things like glucose triglycerides or even specific markers for certain conditions like rheumatoid arthritis.
Okay.
It all depends on the clinical picture and what the other test results are telling us.
It's like a scientific puzzle. But once we have all the pieces in place, How do we actually treat pleural effusion? Is it always a matter of draining the fluid?
That's a great question. It seems like we've covered every possible test imaginable.
Yeah,
But when it comes to actually treating pleural effusion, is draining the fluid always the first step?
that's a good question.
Not necessarily. While draining the fluid, a procedure known as thoracentesis
Okay.
can certainly provide relief from symptoms like shortness of breath. The decision to drain or not depends on a few key factors.
Huh?
First and foremost, we need to consider the underlying cause of the effusion.
Yeah.
If it's a transudate, meaning the fluid is leaking due to pressure imbalances,
Uh-huh.
then simply draining the fluid might not address the root of the problem. We need to focus on treating the underlying condition,
Right.
like heart failure or liver disease, to stop the fluid from reaccumulating.
So in those cases, draining the fluid might be like putting a Band-Aid on a bigger problem.
Exactly.
Yeah.
It might provide temporary relief,
Yeah.
but it won't solve the underlying issue.
Yeah.
Now, if the effusion is an exudate,
Right.
meaning it's caused by inflammation or damage to the pleura itself,
Right.
then draining the fluid can be more beneficial.
Okay.
It allows us to remove infected fluid,
All right.
reduce inflammation, and improve the patient's breathing.
But even with exudates, isn't there a risk that the fluid will just come back?
That's a valid concern.
Oh.
And in some cases, especially if the underlying cause is ongoing like cancer or an inflammatory condition, the fluid might indeed reaccumulate.
Yeah.
That's where other treatment options come in.
Okay, so what are some of those other options? You mentioned a procedure called pleurodesis earlier.
Right.
Can you tell us more about that?
Pleurodesis is a procedure that essentially obliterates the pleural space, preventing fluid from building up again.
Wow.
It involves introducing a substance like talc or doxycycline
Okay.
into the pleural space, which causes the two layers of the pleura to stick together.
So it's like intentionally creating scar tissue to seal off the space.
That's a good way to think about it.
Yeah.
And while it might sound a bit extreme,
Right.
it can be an effective way to prevent recurrent pleural effusions in certain cases.
Yeah.
It's often used for patients with malignant pleural effusions, where the fluid keeps coming back due to the underlying cancer.
So pleurodesis is kind of a last resort when other treatments aren't effective?
Not necessarily. It can be a first-line treatment in certain situations, like
Right.
malignant pleural effusions, but it's certainly not suitable for everyone.
Right.
The decision to perform pleurodesis depends on various factors,
Right.
including the patient's overall health, the underlying cause of the effusion,
Yeah.
and their individual goals and preferences.
It sounds like treatment for pleural effusion is very much individualized with no one-size-fits-all approach.
Absolutely. Every patient is different,
Yeah.
and the best treatment strategy will vary depending on their specific circumstances.
Right.
It's all about weighing the risks and benefits of each option and choosing the approach that best aligns with the patient's needs and goals.
Well, I have to say this deep dive has been incredibly illuminating.
Yeah, it has.
We've explored the anatomy and physiology of the pleural space, delved into the complexities of transudates and exudates, learned about the detective work involved in diagnosing pleural effusion, and even explored the various treatment options available. It's amazing how much information we've uncovered.
And it's just a glimpse into the world of pleural diseases. There's so much ongoing research and innovation in this field.
Yeah.
Constantly pushing the boundaries of our understanding and improving the lives of patients with pleural effusions.
It's truly remarkable. And on that note, I want to thank you, dear listener, for joining us on this deep dive into the fascinating and often complex world of pleural effusion. We encourage you to continue exploring this topic and to always stay curious about the world around you. Until next time, keep on learning and keep on diving.